we're the generation to not just accept it and move on. We're going to demand some answers. And I think that's kind of exciting to be part of that movement.
I'm Anne-Marie McQueen, journalist and proud 50-ish woman, and we are here looking for the true truth in perimenopause, menopause, midlife, and beyond.
Opening our minds to other possibilities is not always easy.
Hop, I think.
You're all woman to me. All right, Anne-Marie.
There we go. Okay, so welcome to the podcast, Amy.
Thanks for having me.
Okay, so I just want to ask you a very general question from your perspective. How are women doing?
It's interesting. I've never been asked that specific question, but I've answered versions of this, and it's really interesting because overall, I'll say not well. But what I think is quite exciting is that this is the generation to not settle. We're demanding answers. We're demanding treatment. We're asking the right questions. We're not settling for certain answers. And when you look at a generation back, if you talk to my mom or if you talk to our parents, they didn't challenge the status quo. When they were experiencing something, they just kind of went with it. And it's when I asked my mom how was perimenopause for her, she was like, "It was fine. It happened," and just kind of accepted it and moved on. We're the generation to not just accept it and move on. We're going to demand some answers, and I think that's kind of exciting to be part of that movement. So I have to hope that things are moving in the right direction. But the unfortunate thing is that, especially in healthcare, change is just very slow.
Yeah. Okay, so you're doing sort of physician-backed fertility and perimenopause at-home monitoring, hormone monitoring, and fertility has a lot to do with perimenopause. Could you just sort of explain to us how they are connected?
Yeah, I guess I can kind of tell you about how we even entered into the space because it happened much more quickly than we had anticipated. So we started the company with a fertility offering because I personally went through an infertility journey and just saw a lot of gaps in the space and wanted to ensure that a woman would not go through what I went through. And so with that being said, we launched this product to help women monitor their hormones over the course of 15 to 20 days. But what started happening is we saw that when we looked at our user base, 46% of our users were above the age of 35. Okay. And then of those users, many of them were telling us that they were perimenopausal. But when you look at their hormone data, right, they're still cycling just fine. And now what's the definition of perimenopause? It's this transition from cycling normally to the moment in menopause when it's been 12 months since your last period. So menopause is just a moment in time. Everything before that is perimenopause. Anything after that is postmenopause. So what we saw in our data is that these women had irregular cycles, yes. But when you peel the onion a little bit more, they tell us that they've always had irregular cycles. The problem was that because they were older, they were just being blanket diagnosed with perimenopause. And it had nothing to do with their actual cycle. So I was like, wait, there has to be more to this that we just don't understand yet. And I don't fault anyone to this, but I do fault society for not asking these questions and demanding answers sooner, right? So that's when we started thinking about what can we do for the perimenopause population, because they need answers, and can we provide that? Can we at least give some clarity? And so that's when we actually expanded our offering to include perimenopause as well.
So do you think, this idea that, I and my friends were having periods, but perhaps weren't ovulating, perhaps weren't as fertile as maybe we thought we were, is informing our perimenopause experience. Can you speak to that? Because I'm super curious about that part.
Yeah, absolutely. And the fact that you're even thinking along those lines is so encouraging, because unfortunately, I don't think a lot of women do. So there's a difference between having a menstrual cycle regularly, so having a period at a regular-ish interval, and actually ovulating. Because what can happen is as you get older, you may still have a regular period, but you might not be releasing an egg every cycle. So when you look at this like 12-month time frame that you're looking at, like from when your last period was, it's not just about was the last time you bled, it's when the last time was you released an egg, right? So it's critical to understand, am I ovulating each cycle, or when was the last time I ovulated? Is my ovulation getting more irregular, to help navigate or that answer of am I going through perimenopause or not?
But let's go back even further. You're not even close to perimenopause. And you're having periods and you're not ovulating. This is happening. And what does that mean? How often is this happening? And what does it mean for your health?
So it all comes back down to hormones, right? If I can give a quick biology lesson, it'll be very quick, I promise. So our hormones work in a cyclical pattern. They're dependent on each other. They work in synchrony, right? So what happens is when you're on your period, everything is at a baseline because nothing should be happening. And we can even take one step further. Like, why are we having a menstrual cycle? We are evolutionary beings. Our role as women in this population is to repopulate the species to ensure that the human race stays on this planet forever, right? So you have a menstrual cycle to optimize your chances of keeping the species going. So during your period, everything is at its baseline. Once your period is over, your estrogen starts to go up, and that pings your pituitary gland to release LH in little bursts. So LH is not coming out in like a steady stream.
Luteinizing hormone, just so people know. Yeah.
Correct. Yes, right. So luteinizing hormone, I'm sorry.
No, that's okay.
It's coming out in little bursts from your pituitary gland. And now as your estrogen starts to rise, that pituitary gland is getting pinged more and more frequently. So the LH starts to rise as well. As the LH is going up, it travels down to the ovary and it tells the ovary, hey, start getting ready to release an egg. We're about to ovulate. When that ovary gets pinged so much, imagine like someone like constantly poking, you're going to break at some point and that egg will come out. Okay. It's going to travel down the fallopian tube into your uterus. As it's doing this, it forms a corpus luteum, which then emits the progesterone. It's this little yellowish structure around the egg that emits progesterone. And the role of that progesterone is to ensure that the uterine lining is as thick and cushiony as possible. So if that egg is to get fertilized, that embryo can implant, right? If that embryo doesn't form or if the implantation doesn't happen, everything shuts down and it says, hey, we didn't get pregnant this cycle. Let's shed everything. All the hormones plummet and it tells the body to have another period, right? So that's the whole function of the menstrual cycle. Now, if something is off, let's say, and maybe something's not even off, but as you're getting older, you might have lower ovarian reserve, so less eggs to release. You might have some sort of a hormonal imbalance that's actually not allowing the LH to come out as frequently as possible to tell the ovary to release an egg. These can all lead to not releasing an egg or not ovulating, or even more scientifically, anovulatory cycles, even though you're having a regular period.
Is that
unfortunately just becomes a little more common as you get older?
Is that considered, like, is ovulation during your lifespan considered important for your overall health?
Absolutely. I mean, like I said, it's part of our role as females in the human race. Like, it is an important, critical component of our overall health. Now, there's so many things that can impact us that we don't have enough data on. Like, so if you're on prolonged birth control, we are one of the first generations to be on such long stints of birth control. You're literally overriding your natural hormonal patterns to make it predictable, follow whatever, it depends on what birth control you're on, but to follow whatever that protocol would be. So it's a little hard to say that it's completely wrong for you because you're already masking it by being on birth control. But if, let's say, you're not on any sort of hormone treatment, being able to ovulate is really critical to your overall health. You want to have a menstrual cycle. You need all that tissue to come out and regenerate itself. Otherwise, you can start heading towards other reproductive disorders that can be much more invasive.
Did you know I also have a Substack? That's just a fancy way of saying I have a newsletter. But listen, it's not like every other newsletter. I am the only journalist in the world who's made menopause my beat. And each week I share research, news, products, tips, and tricks from the world of menopause and midlife. Sometimes I even write an essay. Hot Flash Inc. on Substack is where I pull together everything that's here and in the menosphere, and I break it down just for you. so that we can try and make sense of it all and figure out what to do together in real time. Join more than 5,000 women practitioners, CEOs, and more, and become a subscriber today. You can get my podcast as well as special video and audio drops you can't get anywhere else. Sign up today at hotflashinc.substack.
You're gathering loads and loads of data. So can you just tell me what you're gathering that people might be interested in the perimenopause sort of space?
Sure. So the critical thing that Oova's platform is collecting is your hormone data. So you can go in for an annual blood draw. You can go in for a semi-annual blood draw, but a blood draw is just a snapshot of your hormone levels in that time. As I just explained, our hormones fluctuate on a daily basis. It's like a symphony. You need to hear every beat to understand what that song actually is, right? So with the data that Oova is collecting, we collect luteinizing hormone, progesterone, and estrogen levels over the course of 15 to 20 days. And it's quantitative. So we're getting the actual measurements of these hormones through urine. We also track any symptoms that you want to enter into the app. So this can be, oh my gosh, I think we have like over 40 different things that you can track in there. And then there's also a free text field, so you can put whatever else you'd like. But when it becomes really interesting when you start to correlate hormone patterns with those symptoms. Because when you're talking about perimenopause, unfortunately, there just isn't a lot of data out there. And so you start associating certain symptoms like hot flashes and night sweats to perimenopause. And I've talked to so many of our users where they're like, I'm not sure if I'm in perimenopause because I get hot at night, but it's not like unbearable. I'm like, well, but it's different for you, right? Mm. And so now you have this like competition in your head where, well, it's not as bad as this person, so it must not be this.
Yeah.
And that's not the right way to think about it. So what I love to do is like show our users, okay, look, these are the days that you felt these symptoms. Do you see how your estrogen levels and your progesterone were actually out of whack on these days? And now you're starting to kind of decipher, play some detective work to figure out why these symptoms or what's causing these symptoms to occur.
Okay, so one of the things that we hear, I'm really happy to hear you, not happy to hear you say it, but I'm glad to hear you acknowledge that we don't have much data for perimenopause because people are speaking about perimenopause quite definitively. And I don't know that everyone knows that they're just extrapolating most of the data from menopause and applying it to perimenopause. So I'm curious what you think about that situation.
It's hard, right? Like when you think about women's health, your mind straight goes to fertility and pregnancy. And it's so interesting because that's also where a lot of clinicians spend their time learning, right? That phase of life. But if you think about it, that's also the shortest phase of a woman's life. And not everyone is going to want to get pregnant, and not everyone is going to have difficulty getting pregnant, right? But 100% of women that live to a certain age will go through this transition. And we don't know anything about it. So the unfortunate part is that because we don't know anything about it, people are really like eager to try to find answers, but we're working with the information we have. Mm. It's like you're trying to build this house, but all you have is a hammer and you have some wood, but you don't have any nails. So how are you actually going to keep that structure going? You're going to try the best you can, and hopefully the plank won't fall on you, right? So you're doing a lot of extrapolation, yes, but it's better than nothing.
What about the narrative still about perimenopause is that estrogen falls, and that's what causes most of the problems. And then some of the more forward-thinking people are like, no, it's the progesterone that falls first, and the estrogen is rising and falling, and then you have this situation where you have high estrogen, no one likes to call it dominance, but high estrogen and low progesterone. Where do you sit on that? What do you think when you hear people say your estrogen is leaving the building? It is leaving the building ultimately, but you know what I mean?
Right. No, I agreed. But so that's, again, when the estrogen leaves the building, you're in postmenopause, right? Leading up to it, leading up to menopause, so everything in perimenopause, the one thing that we can say is that your hormones are out of whack. So if you're thinking about the regular menstrual cycle, what's happening is your hormones are no longer following that symphony that we've been talking about. It's starting to kind of go and do its own solo. And unfortunately, these hormones are supposed to work together. So when estrogen drops, but it should be high, progesterone is elevated, and they should be working in the opposite way. And that's when we start getting these symptoms. But what we're seeing in our data is that it's not just like, oh, your estrogen starts to drop and then all these symptoms come in. It's really about a balance between that estrogen and progesterone. And then it also has to do with where you are in that menstrual cycle, because by definition with perimenopause, you are still having a menstrual cycle. It's just irregular. So are we still ovulating? Is there still an egg in there? Is the progesterone supposed to be elevated or not? Is estrogen supposed to be high or not? Things are just so they're out of discord right now that you need to figure out, like the body's trying to figure out how to deal with it, and it comes out in symptoms that we experience.
And
so I don't stand by one or the other.
Okay. And we hear definitively on social media, I hear all the time, you don't bother getting tested for perimenopause. You can't test for perimenopause. You have perimenopause at home hormone monitoring. So I guess you think you can test for perimenopause. Can you explain that part of it?
Sure, absolutely. Yes. So why are people saying that you can't test for perimenopause? Because when you look at the ACOG guidelines, they say we can't rely on hormone data. Well, what is the hormone data that ACOG is relying on? It's an annual blood draw, maybe a semi-annual blood draw. Well, it's hard to draw a line from one data point. As I've been saying, these hormones are fluctuating on a daily basis. So getting one data point is really hard to say, like, yes, you're in perimenopause, because it depends. They're so dynamic. It depends on your cycle day. It depends on where you are in your life journey. Are you actually in perimenopause, menopause, or postmenopause? You can't really tell that based on not knowing what cycle day you're on. So what we're providing is the time series data. So being able to monitor these hormones on a daily basis makes it completely invaluable in understanding what that hormone trend is. If you see that your estrogen is reduced and your progesterone is high on one day, it's hard to make any sort of conclusion from that. But if you see this as a consistent pattern over the course of several days, several weeks, whatever it may be, now you're starting to uncover, hey, something's going on here.
Okay. So you can test for perimenopause with your test.
I think so, yeah.
Also, urine tests and saliva tests get such a bad rap. Like, I just hear people definitively saying that they're a scam and they're a waste of money. And so I'm sure that you've had, how do you respond to that?
I don't disagree. So I'll tell you right now, when I was going through my fertility journey, I was using the over-the-counter ovulation tests. And in the 18 months that we were trying to get pregnant, I only got a high result on 5 days. I never got a peak, and every other day was low. Well, I found out after using Oova that the reason that I was getting those inaccurate results is because my luteinizing hormone peak is just lower than the thresholds of those tests. So right in that moment, I'm like, well, I don't fit that mold. I don't have a regular cycle. I have a hormonal imbalance. I can't use these tests. So when we set out to build Oova, we built something that was quantitative and personalized. So that's the clear distinction for Oova. We are not a threshold-based test. If you're going to go with that, agreed. It's a little bit hard to draw any meaningful picture from a bunch of positives and negatives. But if I'm giving you actual numbers every single day, then you're drawing a very different picture.
And so what will I gain if I'm using Oova, if I'm in perimenopause? What insight will it give me?
So it's going to give you data for sure. And now it depends on what question you're asking. So if you're asking, am I in perimenopause or not? It's giving you a way to track your actual hormones and your symptoms to really see that holistic view of what's going on over the course of time. If you're asking, like, I'm experiencing these symptoms, what's the cause of it? We can also start to address that by seeing if there's any hormonal behavior tied to those symptoms. Because now when you walk into your doctor's office, think about what you're walking in with. You're not just coming in saying, like, I feel off, and like something generic like that. You're walking in saying, like, I've been having a lot of trouble sleeping, and I see that my estrogen is really going low on the nights that I'm getting trouble sleeping. Like, you're having this meaningful conversation with your doctor, where even if you're not getting diagnosed with perimenopause, you are going to be able to have a conversation about, okay, how can I address better sleep? Maybe it's a small dose of estrogen. Maybe it's a birth control that will reduce your progesterone on certain nights. Maybe it's other lifestyle changes that can really improve your estrogen levels. But you're not just coming in saying, I'm off. You're walking in data, really pointed questions, and you're hoping to get actual answers.
Okay, what do you mean progesterone? Lower progesterone? Because I thought you take progesterone to help you sleep.
You can. It affects people in very different ways, right? So like I said, with progesterone and estrogen, they should be working together. So if your progesterone is too elevated, and let's say your progesterone is elevated, but it's not having the effect it should with your estrogen, where your estrogen is also going high, it could work in a negative way. So everyone handles these things slightly differently. You just need to figure out what the right balance is for you.
Yeah, it's really tricky to help women during this time, right? Like what about when you're in perimenopause and you're doing IVF? What's going on then?
Oh, geez. Well, okay. So if you're going through perimenopause and you're going through IVF, the good thing is that with an IVF cycle, they are basically overriding your natural hormonal behavior. They're putting you into a predictive hormone pattern. So you kind of, I don't want to say you ignore the perimenopause, but you're overriding the hormone imbalance that would be happening from perimenopause due to the medications you're on. Also, if you're going through IVF, it depends on whether you're using your own eggs or not. If you are, like you would have done the egg retrieval sooner, so you can also see the quality of those eggs. There's so many factors that you're able to kind of test for if you're going through IVF that can hopefully lead to a successful pregnancy and birth.
Okay. So I want to know, because you're in such a neat space. Like, what do you see in the future for perimenopause and menopause treatment, like genomics and the future of treatments and things that we might not even have thought of?
Oh my God, it's so exciting right now, right? Like the fact that you just asked that question, like it's at the forefront of a lot of women's minds, right? And there's so many amazing companies out there that are doing such cool things in various spaces that I think when you put all this data together, talk about a comprehensive picture of what's going on with your health, right? So I think it's an incredibly exciting time. What we're doing is just the tip of the iceberg. What we're also doing is partnering with a lot of amazing companies that are providing supplementary care that will help you get that full picture of your overall health. So I think it's a really exciting time for the space.
What is there a situation where you've got all these companies collecting data, but I don't know that you have enough actual clinical research happening? You've got all this data. Like, how does it stack up between the clinical research that's being done that's so far behind? How can we marry those up?
Oh, I mean, the companies I like to work with are kind of following and like doing what we do, where every finding that we have, we publish it.
Okay.
So we have been actively publishing our research and our data at every clinical conference since 2021.
Mm-hmm.
And I mean, that's when we started getting powered enough to actually present data. But I like my hope is that it's not just a learning on the consumer side. So yes, of course, like I want women to have this information and understand what's going on with their bodies, but there's also a burden on us to educate the medical community on the advances that are happening. Because if you think about your own job, right? Like you're going into work every day, you kind of get into this grind, you have a routine, you have your rhythm, but there's a lot of change and innovation happening. So where do these clinicians find this? It's through publications and it's through conference presentations. So we've been active in trying to get our data out there to educate the medical community as well.
Okay. And what other ways can you see personalized medicine working for people in perimenopause?
Well, I think it's critical for perimenopause, right? Because as you said earlier, it's so varied. Every woman is handling things differently. They're experiencing different things. Their hormones are behaving differently. So to me, perimenopause specifically, just by the nature of how obtuse this phase is, it's primed for personalized care. We're starting to get really powered to be able to segment our data out really well for perimenopause and start providing some of that. But we really enjoy partnering with others that can provide the next level of clinical care. We're not going to do that in-house, but we can suggest partners that understand how to look at your hormone data and take it to the next level. So, sorry, I didn't realize that my Slack was going crazy. I need to that off. Sorry about that. But yeah, so I think it's really exciting because we have the right partners in place to provide that personalized care that women are craving.
What would you see that would be on the horizon that maybe isn't here yet?
Well, I guess it's here, but I want to scale it.
Mm-hmm.
Is that a good answer? Okay. So what I'm excited about is when you talk to any of our users, they have various questions, but what they all say is that the Oova data helped them feel validated. Because when they walk into their doctor's office and all they have to say is, I feel off, I don't feel like myself, it's the doctor doesn't really know how to treat that. They're not seeing you every day. And it's hard to diagnose, I feel off, right? And it's also hard for a woman to explain how she's feeling off. So when you're able to provide this hormonal data and they put the symptoms to it, and then you share this with a clinician who actually knows how to understand that, the care that they're able to provide is amazing. And I am so excited about the partnerships that we have right now because they do provide that next level of care. And we've heard that from our users as well. And they're just having these really informed conversations. So what I'm hoping for is going forward with perimenopause, it's not this like ambiguous, like gray cloud. There's actually clarity as you're walking through and you're able to have these two-way conversations with your clinician and walk away with a treatment plan or care that you accept.
Okay, when it comes to fertility, like how bad are things? Because we're hearing that things are bad. Like, sperm counts are down, and everyone I know is having IVF. It feels very scary.
Yeah, I mean, I think news and things can make things sound more daunting than they are. It's not. It's a fact that we are not having children as much as we have in the past, right? So there is this risk that the population of the earth is starting to shrink and we're not repopulating it fast enough. And why is that? I mean, lifestyles have changed. Women are having children later, and unfortunately that affects our fertility. Men are having children later, that affects their fertility. These are facts. But what is exciting is that there is a lot of technology out there, like IVF, like IUI, medications like Clomid, that can really help families grow. And so I think it's quite exciting about that part of it. What I think has now become a really big part of the conversation is how do we make these treatments more accessible? Because there's been a pretty hefty price tag on these in the past, but I think clinics are also feeling the pressure to make these options a lot more accessible for their patients. And so that's also quite exciting. And there's so many organizations out there that are fighting for patients to get insurance reimbursement or have their employers cover partial costs, if not all of it. And you'll also see that there's been a pretty massive increase in the number of women that have been freezing their eggs in preparation for having children in the future so they can have the best chance there. So I don't think it's daunting. I think it's actually quite exciting that we're able to utilize this technology in such a positive way.
Oh, that's interesting. Okay. So we hear in perimenopause that you actually sometimes can be more fertile. Is there any truth to that? And how does it happen?
Well, I wonder how much of that is based on just women not really having a regular cycle and not realizing when they're ovulating. Because it is true that your cycle becomes irregular. And what we've also shown is that as women get older, the length of their follicular phase increases as well. So if you think about what we're taught or what we think to be normal, it's a 28-day cycle, you ovulate on cycle day 14, right? That's really not true, but that's what's ingrained in our minds. So if you've been tracking your cycle and you're like, oh, well, I have a 30-day cycle, I guess I ovulate in the middle, and then you might have intercourse unprotected, whatever it may be, outside of cycle day 15. Well, if you're a little older, you may have actually ovulated on cycle day 17, 18, 19, and thought that you had already ovulated. So I think there's just a lack of tracking and a lack of understanding how the cycle actually changes as women get older. That could be leading to kind of a blanket statement like perimenopause women are more fertile.
So you've chosen to track luteinizing hormone, estrogen, and progesterone. Some of the other tests out there in the perimenopause space do AMH, anti-Müllerian hormone. Am I saying that right? And follicle stimulating hormone. What's the difference? Like, why would you measure luteinizing hormone and estrogen, progesterone versus those? I guess follicle stimulating hormone tends to rise as you get later through perimenopause. It's maybe trying to push those follicles out, get you over that.
Sure.
I don't know.
Yeah. No, you're not wrong. So we're a relatively early stage company, so we have to pick and prioritize biomarkers that we want to add to our test in the sequence to an extent. So we have FSH on our list. We just haven't added it yet. And honestly, looking at our hormone data, we're able to get such a solid picture through the pattern of estrogen and progesterone that the FSH would be very much a nice to have versus a need to have for our platform. For AMH, we're most likely not going to add that in the near future to our platform because that hormone doesn't change or fluctuate on a daily basis. If you go in for an annual blood draw, a regular blood draw, that level would be indicative of what it is on like between today and tomorrow. These other four hormones we just talked about, they do fluctuate daily. So you do care about what that pattern looks like over the course of 15 to 20 days. AMH, not so much. It's also a really big hormone, and being able to get that accurately in urine is a bit questionable, and we really want to prioritize our
What do you mean a big
sensitivity.
hormone? Like a big hormone molecule? Or do you mean?
Sorry, it's in size, yes. So like figuring out how it actually metabolizes and comes out in the urine, we want to make sure that what we're measuring in the urine is well correlated in serum. And right now, AMH is not a priority hormone for us.
Is there anything else that is on your list that you would like to test, that any other like DHEA or, like things we might not know about?
Yeah, there's so many things. I mean, our patent covers over 35 different biomarkers. We really want to scale across all areas of women's health. So it's quite exciting for us, like where we're going to be going with this technology. But yeah, there's some really exciting things coming up in the next year.
So you don't want to say, but FSH is on your list. No, it's fine. It's good. Where's Oova going? 35. You've got 35. That's where you're going. Eventually.
Mm-hmm. Yes. Eventually more.
Okay, that's amazing. Anything else that I didn't ask you that you'd like to say that you think is important? Because, fertility is not my thing. I don't know a ton about it, but I am increasingly interested in how it overlaps with perimenopause.
Sure, absolutely. I think you covered a lot of it. I didn't know if you wanted to go over any of the report that we did,
Sure.
That we released a couple of weeks ago. Up to you. Did you receive
No,
that?
I didn't, and I feel bad. But it's probably like because it's crossed over between when I was going to interview you and then when I actually did interview you.
Oh, I'm sorry. I'll make sure that Carrie and everyone sends this over to you, because I think even if you wanted to talk about it, or if you wanted to do a live or something, we could totally do that.
Okay. What's just some of the top lines, and we can end with it, and then I can follow up.
Sure. Perfect. So one of the big things that Oova wants to do is we want to make sure that the conversation around perimenopause is as informed as possible. So what we were seeing through our users is that there was a lot of lack of knowledge, and the perception of perimenopause was so negative. So we decided to do a survey of over 700 women across all 50 states in the US and ask them a bunch of questions around perimenopause and things around like the workplace, treatment, symptoms, their education, where are they going for their information, and so on. And we got a really comprehensive response. And a lot of the data, while not surprising, was really sad to see in numbers. So for example, one of the big findings was that 60.8% of respondents reported they weren't sure they were in perimenopause. And 25% of them actually said that they started experiencing symptoms before the age of 35. So it's an interesting point, because women are trying to get pregnant later in life, yet the signs of perimenopause are starting earlier. So is that the 30s decade seems to be such a critical point of a woman's life in our lifetime right now. And we really don't understand how these two major processes are actually interacting with each other. Another really, I guess, a sad finding was that of our surveys, the women that's we surveyed, only 4.4% of women felt like their clinicians knew how to treat their concerns for perimenopause. And I think that's just so important for us to educate the medical community on what's going on and how to actually treat their patients when they come to them with
4.4%. Wow, that's low, very low. Yeah, I'm not surprised.
I know, and that's the thing that makes me so sad, right? Like I wasn't surprised seeing it either, but then seeing the number was just so daunting, because like, you hear people say, "My clinician doesn't understand me," or doesn't, like even doctors will say, like, "We're not trained in this." But then when you see a number like 4%, like less than 5% of patients felt like the doctors knew how to treat them. That's pretty crazy.
Well, it really is something you have to go and educate yourself on. And, like I always think, doctors have to be smart to go to medical school and graduate. You have to be smart to be a data scientist, but not everyone in your class was amazing at what they do and is going to leave and keep up, right? There's some people who are just going to do their job. And it's same as journalism. There's like some excellent journalists. There's some kind of lame ones. And then there's a bunch of people in the middle. So doctors are going to be exactly the same. And if, it has to behoove them to go and keep up, right? Like unless they're forced.
100%. Absolutely. And I think there's such an interest for it. Like when I went to the Menopause Society meeting last month, it was so like I've never been to a conference where it was literally sold out. And if you didn't arrive at a session 15 minutes in advance, you literally had to stand the entire time. There wasn't a seat available in the entire room. Wow. It was so exciting because people were just so hungry for information and hearing what's new. Yeah. And so that's encouraging, right? Doctors are aware that there's a gap here and they want to fill it.
What's your take on the hormone therapy narrative? Like the narrative that you need hormone therapy to live the rest of your life, basically, to prevent disease and...
I mean, no two women are the same, right? And not everyone's going to experience perimenopause the same way. Some people don't experience any symptoms at all and just go through the transition. They're like, I'm fine. Man, are they lucky. So not everyone will benefit from HRT, but it's a great option if done right. And there's a lot of clinicians out there that know how to do it right. And I think the critical thing is if you're doing HRT, you are literally messing around with your hormones. So understanding how that hormone pattern is, and are we doing everything correctly? Are we too high a dose, too low a dose, what it may be? Understanding that hormone pattern is so critical when you're going through these treatments. So I'm hoping that we can start improving the literacy here.
I absolutely love that you said that because I am not on hormone therapy much. Like I have some, but I'm not on like your traditional estrogen. And I have a couple of friends who are, and one whose care has been just dreadful and seems like she's gone from doctor to doctor to try to fix it. And I feel like she's just seen a bunch of hacks and it's like so scary, right? Because the message is like, go on hormone therapy and people are acting like it's candy. And you've just said, it's like, they're powerful. I think even sometimes more powerful than drugs, like pharmaceuticals.
Absolutely. And especially if you start looking at the good thing about between them is that a lot of the side effects have been evaluated for drugs and not, or for like medications and not for drugs. So I think you're in the positive area with the medication, but not every medication is going to suit everybody. So it's important to be with a doctor that understands how this treatment can work for you. And then most importantly, that you feel comfortable with them. And if you don't, there's so many doctors out there, don't feel like you have to stick with one that doesn't make you feel perfect.
Yeah.
It needs to be a good synergy there.
Well, you're going to be ready for perimenopause. And look what you've done for women who are having fertility issues. And you told me you were in Dubai with your son, so it all worked out.
Yeah, exactly. There's a lot coming from us, so don't count us out yet.
We're going to keep on top of it. I really appreciate speaking to you. And I just think it's so cool how many people are just like branching off and doing this different stuff and helping women. So check out Oova if you want to have this kind of testing. You can test in perimenopause. Remember that next time you hear a doctor saying that tests in perimenopause are a scam.
There we go. Thank you. I appreciate that.
Thank you.
Hot Flash Inc. was created and is hosted by Anne-Marie McQueen, produced and edited by Sonia Mack. The information contained in this podcast is intended for informational purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider, read all labels, and heed all directions and cautions that accompany the products. Information received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, i.e. menopause or anything else, or any healthcare questions, please promptly see your healthcare provider. This podcast, including Anne-Marie McQueen and any producers or editors, disclaim any responsibility from any possible adverse effects from the use of any information contained herein. Opinions of guests on this podcast are their own, and the podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about a guest's qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have direct or indirect financial interest in products or services referred to herein. This podcast is owned by Hot Flash Inc. Media.